Okay, so Navitray. Let's look at the protocol for Navitray. We talk about a case of partially edentulous patient. So not total, of course, but a partially edentulous patient. So what we actually recommend, it's the following. Before taking a CBCT, you take the wafer, the thermoplastic wafer, which is mounted on a fork, and you take the heat gun to heat it up. You will see that the wafer becomes fluffy because of the heating. Then you detach it from the fork, you fold it twice, and you get a little, polygonals of thermoplastic material, which you will be used to take an occlusal key in the area, of course, when you have teeth. You will place it on top of the teeth, mold it, and while it's still soft, you will plug on top the device, the Navitray. This is a very important because the Navitray and the thermoplastic is basically two keys in one. One key, it's occlusal, so it identifies the teeth which are, saddled with the wafer. But there is a second key, which is very important, which is driven by the grooves of this device. If you look at the device internally, it has 7 grooves, vertical grooves. Those grooves, you will find the same on the optical target. So in other words, what occurs that you will be using a Navitray for the CBCT, but in order to let the software automatically register the anatomy onto CBCT, but while you will be plugging the optical target that you will plug onto the key will be the one with the grooves, because the optical target will have the same position as Navitray. So that is the logic behind Navitray.
Why would we choose Navitray over tracing?
Yes.
Or tracing on the teeth, because it implies another CBCT. That's our problem.
Yeah, so there are two options. When you're talking about partially edentulous patients, there are two options. One option is to take a CBCT with Navitray.
Yes.
And the advantage of that option is that the registration is automatic. But you might find a case where a patient shows up at your dental office with a CBCT already done, and he doesn't want to take a second CBCT.
Another one, exactly.
So in that case, because he doesn't want to have a new CBCT, you have the option to use the protocol trace and place. In other words, you will identify the tripod, choosing among the teeth which are in tripod shape. Exactly. And then you will use the tracer to map the volume of the teeth in order to carry
we need
out
to have stable teeth.
Exactly.
Stable CBCT.
Exactly. The condition have no parodontopathic teeth.
There are some conditions. Yeah. We saw in the booklet. We need to have a checklist.
Exactly. Not only that, but there is also a counterindication for Navitray. For example, if you do have not aligned teeth, but you do have open teeth, then placing a thermoplastic on top gets very difficult to take it out, because the thermoplastic stiffens up. When you take out, it is very problematic. So, for example, even if you would like to take one CBCT anew, the fact that you have open teeth discourages you the application of this protocol. Because the exiting of the thermoplastic will be problematic.
Can we use another material instead of the thermoplastic one, so we can be able to remove it?
Yeah, but the question is that because of the material needs to, yeah, I know Impregum, but the material needs to stiffen up. When the material stiffens up, because there is space from one tooth and another, it creates a wedge. So when you're trying to take it out, that wedge forces out the adjacent teeth. So we do not recommend to use Impregum or even our thermoplastic material when you have open teeth.
But an alginate?
Because you might find difficulty in taking it out. So that's the reason why.
Alginato, no, okay. So the alginate is very elastic, so you can remove it easily.
Yeah, the question is, the question is you can try, but the question is that you need to have on top of it another key. There are two keys. One, it's occlusal. One, it's driven by this device. And I mentioned the fact that this device has 7 grooves. If you take the device and you look at the device internally, you will see the grooves. So those grooves on an alginate should be there. And if you manage to have those grooves in the alginate, then you can use the alginate as well, sure. But you need to be careful to have both the teeth, the grooves, and the capability to take it out when you do have open teeth.
If we do not use the Navi tray, we use, the normal dental tracking stuff.
Yeah.
We only use one jaw tracker to the mandible, right? The one with composite.
So, if you're using a trace and place to register, then you need to pick up. You need to pick up an optical target for the patient. Yeah. Which optical target are you going to use? That will depend again on the case. You will use the head tracker, for example, if it's an upper jaw.
In
the upper jaw, exactly. Or you will need to use basically, for example, the BCU tracker, depending if it's edentulous, B, if it has teeth, C, or U, if you want to use basically on metalloceramic. And when I talk about U, the U optical targets basically are 4 in your kit. You get 4 U optical targets. You can use all of them, depending on the positioning you have, because you do have this one, and you do have also other 3. The other 3.
The U tracker is not for Navi tray.
This U tracker.
Yes. So you can use it on normal teeth.
So we need to distinguish between 2 things. Navi tray, it's a means to get registration, and that's it's a different objective. Then there is another area which is tracking the patient. When we track the patient, we need to have an optical target. So, and we can use all optical targets, we have all of them, depending on the anatomy of the patient. For example, we can use this U, for all different cases. You can use U, but the U in this case doesn't have the grooves. So if you look at your U, doesn't have the grooves, so you cannot use it on a thermoplastic which has a second key made of grooves. In that case, you need to use a U-shaped optical target with grooves, which are 3 in your console of optical targets. Because of this doesn't have any groove, you can use it in all different other cases.
How do you use it?
Say it again.
How do you use this one, the U.
So you can put it a impression material.
So
silicone,
any impression material.
any
on
impression
top of
material. This is very convenient because you
Yeah.
don't need to use the wafer we provide you with. You can use any impression material and fix it on the teeth. So that's the reason why we recommend to use this on any impression material and to use our wafer, our thermoplastic wafer, because in that wafer, printing the grooves, it's much easier, and therefore we recommend using the U shape with the grooves with the protocol of Navitray.
We had an argument about if we need an STL file, an intraoral scan for every case, even if it's one implant, 5 or full mouth rehabilitation.
Okay, the answer is no.
You
Why?
Don't need.
No, why you do not need an STL file for each case? Let's talk about a partially dentures patient. Okay.
Yes.
This case.
Yes.
So in this case, you do have a tool in your software, which is a virtual library of teeth. You can pick up the specific tooth, the number 6 for example, in this case, put it on top of in the adjacent teeth, and then place the implant accordingly. So when you talk about 1, 2, 3 implants, you do not need an STL file. Why? Because the occlusal plane, it's already given. You have the rest of the teeth, which are providing you the vertical dimension and the occlusal plane. So you do not need to have an STL file. Why you need an STL file? When you do not have an occlusal plane, you do not have a vertical dimension. So you need to incorporate these 2 pieces of information into Navident. And the only way to incorporate it is if there is a design of the diagnostic workup made by your lab technician, which includes vertical dimension and volume of the teeth. In that case, the only option you have is to import an STL file.
Okay. So can you skip uploading the intraoral scan when you plan the case in Navident? Can you skip the part with STL file?
Yes, indeed.
So,
yes, indeed. When you do recommend the usage,
usually it's uploading the CBCT and then you next, and it's uploading the STL file. Yes,
you can skip. You don't need to follow step by step. You can skip that step and move immediately in add a crown, which will add a crown from a library, a virtual teeth library, and add an implant. That's it, period.
Okay.
What we recommend is to apply only on the total edentulous patient the importation of an STL file. Because in this case, as you can see, you cannot gauge any vertical dimension, nor in the upper, nor in the lower. And you don't have an occlusal plane. In that case, you need to have a design made out of, your lab technician articulator, virtual articulator.
For fully edentulous cases, we saw that some cases were treated with radio-opaque prosthesis and not digital wax-up.
Okay, so
can you tell us why we should go for radio-opaque prosthesis instead of digital wax-up?
So in the protocol of the total edentulous patient, in fact, foresees 2 steps, basically 3 steps. The diagnostic setup, which is turned into STL file, and then a radiologic prosthesis, which is a mock-up with radiopaque landmarks. okay, on it, which are in essence reflected into the STL file. Why we do recommend this solution? And the solution in this case is that your radiologic prosthesis can be transparent, translucent, so it's not necessary to be, radiopaque the whole prosthesis. The only requirements is to have spots, landmarks, radiopaque. Why is that? If you look at the picture here, and I can try to increase the reading of the picture for you to see. So if you look at the picture of this prosthesis, you will see that there are the same dots that we find on the prosthetic radiologic prosthesis. So when you do import the DICOMs, you will see on the DICOMs the mini screws, in this case 4 and occlusally, and the dots, the same dots that you can see here on the patient mouth. You will use the dots to register the STL file. So you will click on this landmark, which is extruded. You see here the extruded landmark. So you will click here and click here. You will click here, which is on the left, on the patient left, and click here. With 3 registration, the software matches the STL onto the DICOMs. And by doing that, this is a breakthrough for you, because now you do have all necessary information. You do have the vertical dimension, you do have the volume of the tooth, and you do have the width of the soft tissue. And now you do have also the bone. So you can plan accordingly, knowing all this information.
So the digital wax-up you are telling us is not enough, because we have to have like a real model and to check it with the wax-up.
So usually the protocol that we recommend is that when you let's talk about this patient. Okay, this is a total edentulous patient, upper and lower.
Yeah.
So you need to plan the prosthesis, and you need to plan the occlusion. So the lab design the wax-up digitally, but then you need to have a mock-up on your hand in order to check if that occlusion phonetically and aesthetically and functionally works well. The only way you can do that if you have a physical mock-up that you can place on the patient mouth and ask the patient to smile, eventually to say something, eventually to try to move, the jaws.
And that to make a CBCT with it.
And so the advantage you have that the mock-up is not only used because of, let's say, for example, there are problems on the mock-up. You can send back to the lab the mock-ups asking to cut some width or some height of a tooth because there's a false contact or there is impediment in the articulation. So you send back the mock-up to your lab, and the lab makes and fix, the occlusion. Then it gets back to you. The advantage you have is that by using the same mock-up, by applying on it some radiopaque landmark, you can use this mock-up in order to capture the landmark. And having those landmarks on DICOMs, you will easily register the STL file on DICOMs. And by registering the STL file on DICOMs, you have all necessary information to carry out a proper planning.
And this is applicable also for maxilla, or only when we have maxilla and mandible?
This is applicable. In this case, you do have both jaws, but can be applied even if you have only one jaw to be treated. Why? Because while the lab gives you the STL file based on the antagonist, so he needs the antagonist from you in terms of impression, either digital or physical, analogic impression. based on the antagonist, it can design the prosthesis. So even if you work on only one single jaw, you have the opportunity to have the mock-up, check on the mock-up, you know, the functionality, the phonetics, and so on and so forth, and then use the same mock-ups with a landmark for the CBCT.
So you place the mini screws.
And you also have to place the mini.
You do the mock-up, you do the CBCT, and then you wait a few days for the...
So this is up to you. You can do it in one day, or you can do on several days. Usually, people tend to have the planning on one day and the surgery on a different day. Why? Because as you can imagine, this is a very complicated case to plan.
Yeah.
So it doesn't take 15 minutes to plan this case, because you need to have all different information, put the information in place, plan the case, and then when the case, eventually you have also to share the case with your patient. Because, for example, you might have 2 treatment plans. As you can see in this case, the surgeon has chosen to place 2 pterygoid implants and 4 vertical implants. But he could have chosen, instead of placing 6 implants, to place 4 implants. So, and there is an impact, economic impact on the treatment plan. So you might find the need not only to plan the case, but also to discuss this case with your patient, because there are some economic consequences if you plan 6 implants or 5 implants or 4 implants. So usually what happens is that you plan the case, and after, you know, tomorrow or the day after tomorrow, you execute the case. But this doesn't forbid to you to manage everything in one day. You have basically the CBCT, you plan the CBCT, and after the CBCT, you go and execute the case. This is something that, depending on how you want to structure your work, can be done in one single day. And there is basically, in essence, this is up to you, how you want to structure, you know, the number of visits that you want to schedule with your patient. Usually there's one visit when you have, you know, the patient and you take a CBCT, and you can have basically that one with the mock-up of the prosthesis. So basically you do have a first visit with your patient when you discuss about aesthetic and phonetics, and then if the patient is happy with that, you can then having the CBCT, and then you can discuss with the patient the number of implants that you're planning to have. And then if you have okay with the phonetics and the aesthetics, and then you have the okay in terms of economic, because this implies a certain amount of cost for the patient, then you can proceed with your surgery. Again, this is a way that we suggest, is not mandatory. You might decide, for example, to skip all this part, place teeth virtually, because you do have a library of virtual teeth, and go straight to surgery. But there are consequences if you proceed in that way. The consequences is that the virtual teeth that you're gonna place are not taking into account the antagonist. So you do not have a vertical dimension when you place a virtual tooth. While if you are placing an STL file, that vertical dimension and the volume of the tooth has been already designed and approved by your patient.
So actually, it's a very simple question, but with a very complex answer. Because we realize we need like a very simple protocol to follow for some 4 or 5 cases. One simple implant and one simple Yeah, for instance,
one central incisor maxillary. How would you, let's say, do the steps for that?
So the incisor, it's the most tricky implant because it's on the aesthetic zone.
we agree.
We know.
Okay, so in that case, my recommendation eventually would be to place an STL file. So although I'm advocating, I told you that on one single implant, you don't need an STL file. I show you basically this picture. I showed you the picture of one implant with basically a crown, no? But this is a molar. So if I place the molar, the implant, above crust, the occlusal side or subcrestal, I do have a papilla here, because usually when you smile, you don't show the first or the second molars. But when you smile, you see the incisor. So the incisor is very tricky because it's not just a surgical protocol, it's an aesthetic protocol. And in order to be aesthetic, you need to provide the patient with a mock-up that you're gonna place on the frontal if it doesn't have the tooth, or eventually a veneer if you are planning in essence to extract the incisor on the day of surgery. But it's important to understand how that will look with the adjacent tooth, because at the end of the day, it's not just the implant, it's the tooth that you want to deliver to your patient. So in those cases, knowing exactly where the papillas lie and knowing exactly the volume of the tooth becomes strategic. Where it becomes also strategic, it's to place the implant at a fixed position, from the adjacent teeth, and therefore that will be done by your planning. So in this case, I would recommend you to get your lab planning an STF file and a mock-up that you can place on mock-up or veneer, depending on when you're going to extract the incisor, with the patient, the aesthetic, and you discuss if the shape and the volume looks fine with the patient. You can discuss before doing the surgery, and then thanks to Navident, you can plan the axis of your implant in a position which is optimal from the papillas that you're going to have on the patient. So that's something that you will need to have. And of course, if you need to cut bone, to reduce bone, in order to get a little more papilla, this is another, again, call that you as a clinician can make in order to manage the soft tissue. But in this case, the management of an incisor requires certain level of application, which are prosthetically, soft tissue management, and surgery. All this can be managed using a Navident. Why? Because I can have the mock-up in a form of an STL file, and I can incorporate to Navident. I can measure the width of the soft tissue, and time, depending on the width I have, trying to understand if the papilla will be affected or not. If I do have a shallow soft tissue, I can decide to have a bone reduction in order to increase the papillae, and I can exactly decide the axis which I'm gonna place the implant between the two adjacent teeth, and then I can go straight to the surgery. So this is the incisor. Of course, if we are talking about the first molar, like in this case, this is much easier because you can place a virtual tooth, and then you don't need even to know the width of the soft tissue. You just go straight and you drill to place the implant. But if we're talking about incisor, canine, that may be a little bit more tricky.
But we can use, instead of STL file, we can use also the incisor if it's in the correct position, and I don't know, it has another problem with.
Yeah. If the incisor is there, and first of all, you need to understand why you're going to place an implant instead of an incisor. So most likely the incisor has been cut, so it's not whole, has been sort of broken by an accident or whatever, or basically the incisor has been devitalized, so it turned black and you want to have it white. So depending on the situation, you need to understand if you can use the incisor as a point of reference. And of course,
if we instead of using let's say our STL file, our intraoral scan, and us planning the access of the implant, can we do a wax up from the technician with the crown in the best position possible, and then we place the implant accordingly to the crown?
Exactly, this is what I'm saying. I'm saying that you get an STL file from the lab technician, and then you use the STL file and the mock-up to plan your surgery. If we are talking about a upper jaw, I recommend using the head tracker. Why the head tracker? Because the head tracker is the only optical target which enables you to have nothing in the mouth. So you can work freely in the mouth without anything. Everything is on the forehead, not in the mouth.
And if it's a free one missing?
And it's what?
Lower incisor.
So if it's a lower incisor, then you do have an option to use the other two, which is basically you can have you can use the Navi tray. If it's a central incisor, you can use a Navi tray on the third quadrant or on the fourth quadrant, and then basically perform the surgery using the optical target for the Navi tray.
But can you use the C tracker?
Say it?
You use the C tracker, composite tracker, instead of Navi tray. We don't like Navi tray.
So if you don't like Navi tray, you will use U tracker, this one.
U tracker or C tracker to put it like in the premolar area, no?
Yeah, you can use either the optical target of Navi tray, the one which have the grooves, or if you do not want to use those optical targets, and you don't want to use a Navi tray, you can use the U, which is a U-shaped optical target on the molar, in premolar.
What's the how can we choose the area accordingly to what?
So
2-3 teeth away, or I don't know.
if you're talking about an incisor on the lower jaw, you will choose basically, ideally, a molar and a premolar, a molar and two premolar, because what you want to achieve a stability of the optical target, which is a U-shaped. So if you place
on the same side or the opposite quadrant?
No, in this case we are talking about the incisor. So we need to talk about, basically depending on if you are right-handed or left-handed, you can choose either on the same quadrant or on the opposite quadrant. For example, if you are talking about, for example, as an example, a 31, and you are a right-handed, my suggestion is to possible swap the contrangle on your left hand and then use the right hand to guide. So if you want to achieve that, you need to have the third quadrant free to work, because you're going to put your contrangle and you're going to put your hand. So on the fourth quadrant, you're going to place the optical target. But if you want to work with your right hand going through the third quadrant, then you go placing the optical target on the third quadrant.
So you're saying the jaw tracker has to be stable and not interrupt us, our
Exactly.
workflow. It doesn't matter actually if it's the third quadrant.
No, it doesn't matter. Correct.
It's
Correct.
important if it's stable and fixed and we don't move it and we don't touch it.
Exactly. That's the priority. Doesn't need to hinder your movements. And your movement, you already know your movements because you plan your movements. Depending on your movement, you choose the position of the optical target.
Impression material would you suggest?
I would suggest a silicone material. A silicone.
More fluid or more hard?
It needs to.
It doesn't matter.
Doesn't matter. It needs to stiffen and to be stable in the patient mouth. So then it becomes impregum. You can use impregum if you want. You mentioned impregum.
Nu mai faceți vestibular,
You can use impregum. You mentioned before impregum. If you have impregum, use impregum. Impregum is fine.
Can you make like a type of the study case? If we have, for instance, missing 2, 3, 2, 4, only this.
So you miss 2, 3, and 4.
2, 3, 2, 4.
2, 3, and 4.
2, 3, point. 2, 4.
23, 24.
23. Okay, 23, 24. So if you miss 23 and 24, then you treat it as basically because you are working on the second quadrant. My suggestion is to use the head tracker. So basically, you use the head tracker for tracking, and in terms of planning.
Okay. And if it's 34, 34, 33, 34.
So if you're using a 33 and 34, 33 and 24, I'm suggesting you're gonna place the optical target, eventually again using a U shape if you want, or if you have natural teeth, you can use a flow and composite, and you can fix this between the two incisors, 31 and 41. So what you will be doing, at the end of the cable, you bend the cable in a hook, and then you saddle the hook in between the two incisors. Then you place flow and composite, and you fix it. And then, because it's 32 and 34, my suggestion is you swap the contrangle from right to left, and you work starting from the third quadrant directly on the implant sides.
It's important to keep it close to the edentulous area.
No. In this case,
I mean, why do you choose the 31 area and not?
In this case, my suggestion is you place it between 31 and 41, again from an ergonomic standpoint, because you want to work freely, either going through the third quadrant or the fourth quadrant, and placing it between 31 and 41 enables you to work freely.
If we are missing from, let's say, 34 to the end, we're missing all.
Okay.
Terminal
Indentation, yeah.
Exactly. So,
Unit.
so you do have only the canine, for incisor canine. Then from the canine onward, you miss everything. So in this case,
we don't have the tripod for that.
In this case, it depends. If you do have the 16 or 17, then you do have a tripod, because you have, you have the 23.
No, 30.
Sorry, you still have 33 and 46. 33 and 46 is a tripod.
No, we don't have anything behind the canine.
Okay, in both
We have
arches.
only 6 teeth.
Okay.
From canine to canine, and that's it. And we have nothing in the lateral side.
In that case, you need to place mini screws. So you need to place one mini screw. Eventually, if you want to treat both arches, semi-arches, both the left and the right semi-arch, you need to place one mini screw, possibly distally. And again, you need to understand which type of implant you're going to place, because if you are going to place, for example, a pterygoid implant, 2 pterygoid implants, then you can place the mini screws and the pterygoid exit at number 7.
We're talking about the mandible.
Okay, sorry. In the mandible,
place only on the lateral side, and we have nothing.
Then in that case, you're talking about the mandible, and then in that case,
we have to place a mini screw in the back.
So you can choose 2 positions for the mini screw. You can position 2 positions. If you don't have teeth, you can place it occlusally. You can place occlusally somewhere, or if you do have teeth and you have the area in which you want to place the implant very constrained, you can place the mini screw above the flange, very high on the flange. You see, on the upper part of the vestibular part of the patient. So you do have the vestibular part here, and you can place vestibularly the mini screws. Or if you
posterior, like in the second molar.
Yeah, you can choose number 5. You can choose number 6. You can choose number 7. Depending on where you're gonna place your implant, you choose the area where you want to place an implant, ideally, to place a mini screw, either vertical or horizontal.
The mini screws, you have to make a CBCT again, and then make the digital wax-up and the planning. No?
My suggestion is that you do an OPG on the patient, and you see that the patient doesn't have from a canine onward on both semi-arch. So you basically, based on the situation, you decide how many implants you're gonna place. Are you gonna place a bridge? Are you gonna place 6 implants? Are you gonna place, then based on the idea that you want to place, the number of implants you want to place, let's just say that you wanna place a number 5 and a number 6, or a number 5 or number 7, then in the area where you won't have an implant, you're gonna place a mini screw. How you're gonna place the mini screw depends if you do have the possibility you will place occlusally, so vertical, or eventually you can place it also vestibularly, horizontally, depending on what? Depending on the width and the height of the bone. If you do have a big absorption of the bone, then therefore you have the nerve, therefore you want to place it occlusally to stay away from the nerve, or if you do have a space, you can place it vertically, but this needs to be done by looking at the anatomy, and an idea of the anatomy is given by the OPG.
We place the mini screws, we make the CBCT, and then we have to plan. But we make, let's say we can use we don't have to make a digital wax-up. Maybe we can use the system.
Yes, in this case, because you do have from canine to canine, you already have the occlusal plane. So you need to follow the occlusal plane, and you need to.
Let's say we have a good occlusal
and you need to
plane.
follow the occlusal plane until the 7.
Yeah.
Using the virtual teeth that is in the program.
Okay, then we make the implant planning, and what tracker do we use?
So in that case, again, my suggestion is to use either the C with basically flow and composite between 31 and 41. Okay, this is very convenient. Or you might even use the U shape, but with the U shape, you need to embrace from lateral to lateral. So because of the U shape, it's from lateral to lateral, you should always have 2 mini screws and at least 1 canine visible in order to perform tracing. Because in order to perform tracing, you need at least 3 points. The 3 points for you will be the 2 mini screws and at least 1 canine. So if you're gonna use the U shape, at least 1 canine should be left alone in order to be traced.
Că la copii și deja din 6 dinți le acoperi jumătate din câmp și tu trebuie să trecuiești pe acolo.
A zis să scosezi măcar un canin liber. Că ai 2 puncte și rubule din spate și un canin în față și a făcut 3.
About bone reduction. So again, the protocol for bone reduction, you plant the implant where you're gonna be placing them under bone. So you need to plan first, then place the implants, and after placing the implants, you will be using a diamond burr to reduce the bone. So this would be applicable for all bone reduction. You never reduce the bone before, you reduce the bone after placing the implant, not before placing the implant.
In the soft, we can make this kind of digital wax up, even if it's not very precise.
Yes, these are all these teeth are the virtual teeth. These are the virtual teeth. But the problem of these teeth are not designed.
You don't have occlusion.
The antagonist. There is no knowledge about the antagonist.
Sagittal orientation.
While when you do have a prosthesis designed using an articulator, a digital articulator, then you do have the antagonist, which is a very important piece of information because it affects the occlusion and affects TGM.